Good evening, everybody. It's my pleasure to invite you all to the next webinar in the Diabetic Food Society of India's webinar series. And I'm very happy to welcome Professor VENU KAVARTHAPU from King's College, London. He's an consultant orthopedic surgeon at King's College Hospital, London, and he's an orthopedic lead in the King's Diabetic Foot Unit. He's also the training program director of orthopedics in Southeast London region, and he was the president of Indian Orthopedic Society of UK between 2013 and 2015, and he is the chairman of British Indian Clinical and Academic Partnership. He is an expert in managing Charcot, and he is also the president-elect of Association of Diabetic Foot Surgeons. I would now like to welcome Professor VENU to start his presentation on Charcot foot in diabetes.
Thank you very much.
Yeah.
Thank you very much, Rajesh, for that introduction. I'm good to go now. So I bring greetings from London and from my institute, King's College Hospital, which is part of a group of hospitals in London, which includes Guy's Hospital, St. Thomas's, and that group is called King's Health Partners. And we run one of the largest diabetic foot care facility in UK. So just to recap this magnitude of the problems we're all facing with a large burden of patients presenting with problems in their feet, and those patients happen to have diabetes. The lifetime risk of a person with diabetes developing a diabetic foot ulcer has actually gone up. It was thought that it was around 25%, now it is up to 35%, perhaps because the patients are living longer with diabetes and therefore subjected to developing ulceration during their lifetime. But the problem is that some of these ulcers result in a major amputation, and 85% of major amputations are preceded by a foot ulcer. The problem with a major amputation is that a lot of these people with diabetes, if they lose their leg, they lose their life as well. And this mortality rate is worse than common cancers. And again, this problem often starts with a simple ulcer. So what are the reasons for people with diabetes developing a series of events resulting in amputation? Well, the basic pathophysiology here is the involvement of vascular component of the limb and also the associated infection and the deformity as well. Again, 80% of these are potentially preventable, these amputations are, if we address these three super pathologies. And relevant to this talk, most of the problems that lead to amputation in my practice are the patients that are present with deformity, and hindfoot and midfoot Charcot neuroarthropathy tends to be the main underlying reason. So Charcot neuroarthropathy, again, just to recap the history regarding this very intriguing pathology, even though Jean Martin Charcot described this condition in 1868 in patients with tabes dorsalis, but it was not until in 1936 when Jordan found the association of this particular condition with diabetes. And it has been a long time, but still, we are still not very clear on the pathophysiology. But we know that this happens to those people who have peripheral neuropathy, not just from diabetes, any condition that results in peripheral neuropathy. Now, diabetes is the leading cause for peripheral neuropathy. And this is also known to decrease the life expectancy of those people by about 14 years. And so it also decreases the quality of life, particularly those people who lose a limb and then life a number of years before their death. The quality of life is very poor because they're not that mobile. And the lower extremity amputations among people with Charcot neuroarthropathy is between 3 to 9%. So it's very significant. So before I proceed with my full talk, I would like to bring to your attention some useful books to read, and these two are the ones I found the most helpful. Well, what happens in Charcot neuroarthropathy? It presents as an acute event, and usually the patient describes that the patient felt some unexplained, painless, red, warm, swollen foot. The patient might say that I woke up this morning and now cannot get my foot inside my shoe, or while I was walking along, I suddenly heard a crack and my foot started to swell up. And this is the kind of description typically given in Professor Edmonds' book. So when you examine these patients, the patients present with a warm, swollen, red foot and ankle region. There can be a deformity, particularly if the presentation is a bit late. Again, if you feel the foot region, they can be crepitous. It feels crunchy, usually because the bones are moving. If in advanced presentation, it can be like a back of bones. So it's really important that we measure the skin temperature and compare with the opposite side to see if there's any significant temperature difference. How much is significant? It is variable, but by and large, if it is more than 2 degrees, the degree of local inflammation there is quite significant. And that usually means that there is a Charcot neuroarthropathy. So now what happens in Charcot neuroarthropathy during the acute event, usually due to some primary injury? Quite often the patients don't recognize or recollect or give that much importance to this injury that can be minor. But that triggers really, really uncontrolled inflammation. And that's because of the presence of neuropathy, the patients don't feel much sensation. So the patients don't feel much pain. So they continue to weight bear on that limb, and that leads to secondary trauma. And then this whole pathology of acute Charcot neuroarthropathy develops. So acute Charcot is nothing but a very uncontrolled, unregulated, localized inflammation in the foot and ankle. But with time, with treatment, it becomes a non-active Charcot, and you can call this as a chronic Charcot. And finally, it becomes a healed Charcot. But during this process, it can develop a deformity. So this is the kind of life, this is how the Charcot condition progresses, and at any point, it can lead to certain events resulting in threatening of the limb. So a red, warm, swollen foot should be considered as a Charcot foot until proven otherwise. So if you suspect that, you should ask the patient to commence non-weight bearing mobilization. And if you don't have access to a multidisciplinary team, you better refer the patient to such facility. But you can also think about the differential diagnosis. Not all acutely swollen red warm foot is a Charcot, but you need to prove it otherwise if it is not. For example, cellulitis or osteomyelitis can, but if there is no portal of entry for infection, it's extremely unlikely that it is cellulitis. In fact, this is the commonest misdiagnosis among patients with diabetic neuropathy. And the CRP tends to be very high, more than 50. In an acute Charcot, because it is an inflammatory process, the CRP still goes up, but by a very, very low level. It can be gout as well, or it can be a deep vein thrombosis. So you can investigate that presentation further. The blood investigations can be numerous, but it should include the usual full blood count and C-reactive protein. But imaging has a massive role. Clinical examination and imaging both have a significant role. So the imaging part, again, full spectrum of imaging. Ultrasound aspiration is very helpful if you suspect infection. Aspiration, ultrasound can show the presence of any collection, and if you aspirate and if you do microbiological analysis, that can rule out infection, because that tends to be the commonest misdiagnosis. But let's go through the other imaging investigations. Plain radiographs in an acute presentation are normal, and it is called stage 0. I will take you through later. But by and large, in delayed presentations, you see a spectrum of changes depending on the staging of the disease, but in the end, it leads to destruction of the bones, dislocation of the joints, it creates joint debris, bone debris, it also leads to disorganization of the bones, and you can see density or sclerosis of the bones. So the typical 5D description of radiographs. But serial radiographs are critical. If a patient comes with a clinical evidence of potential acute Charcot, and if your initial X-ray is normal, in this patient, a hindfoot or midfoot acute Charcot was suspected, but those X-rays were normal. But the foot is swollen. Either you can do an MRI or other investigations, which we'll go through later, or most importantly, you should do serial imaging because you might see the actual bone changes later. It takes a minimum of 2 weeks before you see any changes in the bones following the onset of acute Charcot. But MRI is considered as a gold standard. So what do you see on MRI? You generally see soft tissue edema around the area where you see swelling, along with periarticular bone marrow edema, which is really, really critical. And the distribution of this periarticular bone marrow edema is also characteristic in terms of the location of the Charcot neuroarthropathy. You can clearly see in these images the calcaneal and distal tibial or navicular, similarly on the dorsoplanar. So MRI was not very well understood its role for the diagnosis of acute Charcot in the past, but a considerable amount of work has been done, and now it is a lot more clearer on its role. Perhaps this particular algorithm shows us how MRI can be helpful. So you have an acute Charcot presentation, and the plain radiographs don't show a cortical fracture, or even your clinical examination doesn't show. So that can be graded as a low grade, grade 0. So because the inflammation response there is probably mild, so it hasn't developed full-blown acute Charcot as yet. There's no skeletal deformity, X-rays are normal, but the MRI is abnormal. That is because of microfracture. So that's still, so MRI is very useful in that kind of very subtle presentations. But if there isn't a cortical fracture, it is a high grade because the inflammation is already quite severe by that time. And there may be some skeletal deformity as well. The X-rays are clearly abnormal. MRI will also be abnormal, but you'll still see that extent of bone marrow edema and bone bruise, because that baseline MRI will be very useful to decide when to stop the Charcot treatment. So on the other hand, when you think that acute Charcot has become non-acute or chronic. Other investigations such as CT SPECT imaging are very helpful. CT SPECT imaging, basically this shows high uptake in all 3 nuclear imaging modes. With these investigations, you can stage the Charcot process, and the classical classification for the staging is Eikenholz, which classifies these pathologies into fragmentation, where the bones are really, the acute presentation where the bones are fragmented, and then the bones start joining together, the coalescence stage, a second stage, and the third stage is consolidation. So the bone reaction healing is over, and the deformity at this stage becomes absolutely permanent. But however, based on the MRI imaging findings, we now know that there is stage 0, which was described by Chantalou. So that is called pre-radiographic. So if the radiograph is normal, but the MRI shows abnormality, typical of Charcot pattern, so that is stage 0. But I would like to emphasize that a red, warm, swollen foot should be considered as a Charcot foot until proved otherwise. Again, in that situation, you should commence offloading immediately, and you should provide multidisciplinary care. So another algorithm, very useful one. So red, hot, swollen foot, and clinically, we suspect this as a Charcot. So you should initiate casting therapy, but you may not have a full diagnosis by that time, but initiate casting therapy, and if necessary, non-weight bearing. So do weight bearing foot and ankle X-rays. plain radiographs, non-weight bearing radiographs are not that helpful. So you need to load those bones to see that bone displacement and distraction. If it shows Charcot changes, which means subchondral fractures and displacement of the bones or joints, then it is diagnosis, Charcot stage 1. But if you don't see such changes, then fine, you need to proceed with either MRI or CT SPECT, and the CT SPECT 3-phase positive scan in all phases with fractures as well, or bone marrow edema with or without fractures and MRI that confirms an acute Charcot. So that is staged at stage 0. So the management of an acute Charcot is to, on 3 folds. The aim is to prevent the progression of the deformity very clearly, to achieve full resolution of inflammation. Even if you do nothing, the inflammation might still resolve, but it will take ages, and by that time it will develop bad deformity. Prevent pressure ulceration during the whole treatment, but most importantly, prevent recurrence of Charcot. We want to get the Charcot completely healed, and we want to manage such a way that the risk of recurrence is reduced. Is there any role of medical treatment in an acute Charcot? Very little. So anti-resorptive therapies were trialed, and there was no significant effect on temperature reduction, maybe some improvement in bone density, but no significant. Again, recombinant human parathyroid hormone showed no significant benefit, and rankle antibodies show some potential benefit, and that might hold the key. We still don't know yet. A low intensity ultrasound stimulation showed some positive findings in certain small series. Similarly, electrical stimulation, magnetic stimulation. No, people are really, clinicians are really out of desperation trying all sorts of medical treatment. But it appears that the gold standard treatment for Charcot is offloading. And the gold standard method of offloading is total contact casting. So total contact casting is known to facilitate even distribution of plantar pressures in the sole of the foot and transfer those pressures to the leg. And it also reduces edema in the lower leg and ankle, because thereby it reduces inflammation. That's the reason. So that in turn reduces bone fragmentation. It also prevents the progression of deformity. So there's no doubt that total contact casting is the best way to offload an acute Charcot. So there are different ways of putting a total contact cast on. At King's, our team does this way, and these are the pictures taken. You first apply cream to the foot and leg to prevent any scaling. Then apply wool around the toes. Then you need to protect the pressure points wherever they are. You need to put felt over those bone prominences and pressure points. And then weld band. I know that the original description of total contact cast did not have much of soft layers usage, but we find this is the best and safest way to do. So apply full cast, and when you apply the first layer, the toes are not fully covered, and then the second layer where the toes are fully covered, that gives slightly wider toe box, and you have fully done total contact cast. So ideally, the patient is mobilized non-weight bearing in an aggressively acute Charcot. But early stage 0 patients can be managed with full weight bearing. If non-weight bearing is not possible, there are ways of offloading the foot and ankle part of the limb using this whole limb. This is the knee is called the knee scooter, and a lot of our patients need such type of additional offloading measures. If the total contact cast is not possible, the standard total contact cast, the next best option we feel is a bivalve total contact cast. Still a total contact cast, but the patient can take the top part from time to time. Otherwise, custom-made one, or if the foot shape is normal, you can consider using the off-the-shelf braces. So what is the duration of this offloading? If you look at the literature, it is somewhere between 6 to 18 months. Certainly in Europe or at King's Cross Hospital, the duration is slightly longer than the duration observed in the US. But if you identify stage 0, and if you commence treatment at that early stage, it will in most situations be less than 6 months. How do we know when to stop offloading? And that offloading has to be done in a graded manner. So, well, persistent resolution of inflammation. The swelling it comes down and should stay down. The temperature difference normalizes and it stays down. So you do serial X-rays. If you see stage 2, and if the clinical features are favorable, and we can commence gradual return to normal weight bearing. But if you done an MRI, and if you know the amount of bone marrow edema in the first MRI, then when you feel that clinically and from plain radiographs that there is adequate resolution of the acute Charcot inflammation, you can repeat the MRI. If that shows significant reduction in bone marrow edema, that will definitely indicate completion of your offloading. And clinical examination is also critical. The edema can resolve, the bones can improve, but there can be associated mechanical instability in some feet. And those feet with mechanical instability, if you let them weight bear, number one, they can't properly weight bear on that limb. Number two, the risk of reactivation of Charcot is very high. And 3, the risk of ulceration is very high. It's not just the deformity. You need to look at the instability part as well. So let's have a look at the sequence of events in an acute Charcot. You have commenced an immediate offloading of that acute Charcot, and if that is continued for a period of time, you will see consolidation in most feet. Then, if the foot shape is not so bad, they can mobilize with surgical shoes. But if there is any bone prominence here and there, that can cause, that leads to ulceration. You can do exostectomy, means just removal of that bone prominence. But if there is a large deformity, you can do reconstruction. But the number of patients that need reconstruction is very small. Exostectomy is slightly higher, but most patients can manage well in surgical shoes. If you commence immediate offloading, means most patients don't develop significant deformity if you develop immediate offloading. Some patients, however, despite this immediate offloading, continues to develop progressive instability, and the foot continues to deform even inside the total contact cast. And that deformity, the fixed shape of the cast and foot, is very fluidy inside, and that leads to point pressures and ulceration getting infected, and finally the foot at risk of amputation. So a small portion of an acute Charcot presentations don't respond to your offloading measures, and those patients are at risk of losing the limb. If the foot is at risk in that kind of situation, it's important that you admit the patient so that you can commence strict non-weight bearing mobilization, and also while the patient in the hospital, you can continue on total contact cast. And you can keep monitoring the temperature difference, swelling reduction. But if obviously the patient has already developed a deformity, if the temperature difference is favorable, then and the swelling is reduced, then you might need to proceed with fixation, because that kind of unstable deformed foot will not allow normal weight bearing. So in those foot at risk patients, it's most likely that most patients will require a surgery to prevent any risk of losing the limb. But that surgery can only be delivered in a multidisciplinary diabetic foot team setup. And in our unit, we have the diabetologist, who is the lead, our team lead, Then podiatrists. Podiatrists are like our gatekeepers, orthotists, and then the surgeon. In our unit, it is predominantly led by orthopedic surgeons, but in other units, it can be a different surgeon. So a vascular surgeon provides support on the vascular side. A plastic surgeon can provide support on the plastic side. And microbiologists and radiologists. These are the core multidisciplinary team members in our unit. So let's go through a couple of examples of an acute Charcot. In this 62-year-old patient with type 1 neuropathy, developed these acute Charcot changes, but it started with some swelling following a minor trauma, but the local casualty did not appreciate that. The patient was allowed to continue to weight bear, and then everything became quite severe. So the medial cuneiform has totally extruded. The whole midfoot, you can see, is disorganized, and that extruded medial cuneiform put pressure on the skin, causing this ulceration. And at this point, this patient was referred to our multidisciplinary clinic. So immediate debridement of the ulcer and temporary fixation of the bone, along with bone removal done, but that doesn't allow us to correct the foot shape. The foot shape correction requires surgery. And on this occasion, we were able to correct the foot shape by doing this kind of plate fixation surgery. In an acute presentation, the ulcer was infected and the ulcer was debrided. We left the wound open. On this occasion, we didn't have to take any help from a plastic surgical colleague. As long as you correct the deformity and instability, remove all the infected material, ulcer healing is very, very predictable. In a total contact cast, initially with vac dressing until you see the granulation, and then total contact cast, then you get good skin cover. And this patient was able to fully weight bear at about 5 months' time. Another example of this time, Hindfoot, a bit more limb threatening. In this patient, patient came from overseas with very severe comorbidities and ankle fracture dislocation. But the point here is that there was no significant trauma. He had a very, very minor sprain and the whole ankle dislocated. So that is Charcot, not a proper skeletal trauma. A proper ankle fracture of this nature requires mega trauma. So obviously you can see that is the shape of the cast the patient came in, and that is the shape of the foot, and the medial malleolus is protruding through an opening in the cast. So that required, this is quite a critical limb threatening condition. So radical ulcer debridement using approach through the ulcer on the medial side. You need to correct the deformity. You may not achieve full deformity correction, whatever. You need to improve the deformity, or if you can correct the deformity, then only the pressure on the skin will come down. That will improve the microcirculation of the skin and soft tissues around that area. And that will also allow us achieve ulcer healing. So we take deep tissue samples on every patient that present to us with an ulcer. We do bone biopsies in the outpatient clinic, every patient that present with any suspected infection. So microbiological diagnosis is really critical. If you have the microbiological diagnosis, you have full power on that infection. So again, remove that medial malleolar bone prominence. And once what we do is we monitor the clinical and serological response. If clinically the ulcer healing progresses very rapidly, if the sugar levels are very well under control, and then serologically if the CRP comes down to normal and stays down, then that is a time when we go back and do reconstruction. So in an acute Charcot neuroarthropathy situation, which is a painless, swollen, warm, and red foot with minimal or no trauma in the presence of neuropathy, is an acute Charcot unless proved otherwise. And in fact, so many mistakes we have seen are being made by diagnosing this as something else. In this situation, immediate offloading and multidisciplinary care is absolutely critical. However, you don't get all acute Charcots referred to you. Some of them don't get treated. On this patient, she had that first episode about 3.5 months earlier, but it was not fully treated. In this example as well, not treated, and you can see the degree of deformity or instability this leads to. Or not inadequately treated. In this patient was treated with a frame, circular frame, and the deformity correction was pretty good, but bone fusion was not aimed at, it was not achieved. So if the bones don't join together, it's only a matter of time before the foot deformity recurs. You know, in Charcot, you have significant muscular imbalance as well due to the motor neuropathy component as well. So this is a progressive deformity. Unless if you achieve full bone fusion, the deformity recurs. This is another example, very severe deformity. So if there is deformity, whether it is in the forefoot or midfoot or the hindfoot, there is peak plantar pressure, and you can, by changing the footwear, the shape of the footwear that matches the shape of that foot, you may be able to reduce the peak plantar pressures as long if the foot shape is not so badly deformed. Means if the deformity is not so bad, yes, you can still achieve good pressure relief from these measures if the deformity is mild to moderate. But if the deformity is severe, or if there is instability, you simply cannot achieve offloading with any methods. In those situations, it is important that there is a provision to correct the deformity. So what are the surgical treatment options in this group of patients? Chronic inactive Charcot foot with deformities as the examples we have seen. So, okay, well, you can continue with offloading, but if it leads to ulceration, you might consider just simply debriding the ulcer, but because the deformity is still there, the ulcer will recur. Or you can remove the localized bone prominence, which is called exostectomy, but with exostectomy, the overall foot shape still stays the same. But overall foot shape is significantly abnormal. You need to reconstruct. You need to correct the shape back to normal. That can be only midfoot reconstruction or hindfoot reconstruction, or in some cases, both midfoot and hindfoot together. Exostectomy is a very powerful procedure, and that is often underutilized. So in this patient with chronic recurrent non-healing ulcer with bone prominence here, so you do ulcer debridement. Ulcer debridement has to be very aggressive. All of that area is infected, necrotic, fibrotic. We use a concept called RAG, red, amber, green. Red is the obviously infected part. Amber is the fibrotic reactive part around the red zone. That needs to be completely excised as well until you reach the green zone. So seemingly small ulcers may have a large area of amber zone, and you have to excise all of that, otherwise you don't get good healing response. Amazingly, if you excise all of that, including removing the pressure by doing exostectomy, the healing response is fantastic, even though you have a large ulcer. Or you might consider local transposition flaps, local rotational flaps, and so on. So here the midfoot, you can see it looks very broad, and there is some medial lateral prominence as well, but we decided not to go ahead with full reconstruction, and we did just simple exostectomy and release of Achilles tendon to get the foot plantigrade. So you can see before that was the amount of plantar flexion, but with Achilles tendon release, you got a plantigrade foot. That was the size of the defect, and that was then managed with vac dressing and serial change of vac dressings, and then total contact cast. Then you get a nice flat surface. So there is no bone prominence there. So on this occasion, this patient had full soft tissue healing. But that foot has to be offloaded in an appropriate custom-made shoes with insoles. Otherwise, the risk of recurrence is high. But that is with exostectomy. But if we talk about major deformities, these deformities don't respond to exostectomy. We need to reconstruct. and they come in so many different shapes with associated additional vascular and other comorbidities. So these are done for limb salvage, because if you don't reconstruct, usually the patients lose their limbs. To maintain their mobility, if they lose their mobility, they die. They die very, in a short period of time. If the foot shape is improved so that the patient can walk in a shoe, that is ideal. And also to prevent recurrent ulcerations. So the solution for such presentations is a major Charcot foot reconstruction. Why hasn't it been done until recently? I mean, this is quite challenging because the existing bone is, quite a lot of it has disappeared. Even the existing bone has very poor healing potential. They often come with wounds and ulcerations. Skin coverage can be quite challenging in most patients. And also, we are most familiar with internal fixation. Internal fixation was thought that it would fail in these presentations, but the external fixation also has a very high failure rate. And in fact, most patients find it difficult to tolerate external fixation for such a longer period of time. So, and it was not a surprise that this was the only below knee amputation was the only treatment offered to these patients for a long period of time. But if you apply the standard diabetic foot treatment principles, and this is the set of principles given by Professor Michael Edmonds in his books and his talks: wound control, mechanical control, which is essentially the surgery we're doing, microbiological control. If there is an infection, you really need to have a microbiological diagnosis of that infection and treat with targeted IV antibiotics. The best way you can achieve that is by doing bone biopsies and deep tissue samples. And we have published a few scientific articles on that. Vascular control is very critical. All these patients need to be adequately assessed on the vascular side, and if required, they need to undergo a vascular procedure, revascular procedure prior to the reconstruction. Metabolic control, their sugars and general medical condition need to be optimized, and education control as well. This is a kind of contract between the surgeons on the team and the patient as well. And we need to educate the patient completely about this so that the patient is fully compliant. So let's go through the modern multidisciplinary surgical approach we follow at King's College Hospital. Very aggressive vascular management, very aggressive targeted infection control, advanced wound care, and also we identified a significant problem with the fixation technique that was used before, and we modified that to using specific principles. But multidisciplinary approach is critical. And Professor Edmonds and his team had published the outcomes with the introduction of multidisciplinary care in diabetic foot surveys in 1986. That was, they were really learning about the benefits from multidisciplinary care, but now we have a very, very large unit. It has been going on for 35 years. It's a one-stop clinic for diabetic foot patients, and most recently the attendances were about 13,000. So we run combined orthopedic clinics. I run twice a week, and then combined vascular clinics twice a week, and then they do follow-up clinics, acute Charcot clinics, and so on. So our core team has expanded now. So these are the list of the core MDT members, and this was the team about 8 years ago when we received some national award. But this is the same team that look after these dirty feet as well. Our recent amputation rate was found to be very low. So what we do is, once we decide that this patient requires a Charcot foot reconstruction, often the patients come from everywhere in the country, so we need to really provide them very targeted educational control. So we run foot school, a special clinic only for those patients on the waiting list to have this surgery done. About if patients are waiting to be done, they are brought to this clinic along with their family members as well, and we spend the whole morning teaching them and educating them on all aspects of the treatment they're going to receive. And that is our diabetologist talking about the medical aspect, and the podiatrist will talk about the podiatric care, orthopedic colleague will take them through surgery, physiotherapist, occupational therapist, and so on. We spend quite a bit of time counseling them. These patients, along with peripheral neuropathy, they also have some degree of difficulty in cognitive retention. So we need to really spend quite a bit of time. We need to make sure that there is a good microenvironment setup. When they go home, they might need to be non-weight bearing for a period of time. We need to make sure that their stays are safe and they have adequate support at home. Then surgical planning. This has revolutionized our ability to reconstruct these feet. So whatever we do, it has to be centered around the patient. So if we need to do certain type of reconstruction that allows the patient just to walk a few steps, that's what the patient wants, then you don't need to do a 10-hour procedure. But some active patients might require much aggressive reconstruction so that the patient can keep the jobs and so on. So, when we started doing reconstructions about 16 years ago, there were some early failures, but midfoot reconstruction failures from globally made us think innovatively and come with solutions. So basically, this is a patient that had midfoot Charcot reconstruction about 17-18 years ago before I joined. And you can see the picture on the left side, that's the Charcot deformity. And the second picture shows fixation of the deformity correction. It's corrected nicely and it has been fixed with these various fixation devices. And about 5 to 6 months later, the fixation has failed and the deformity recurred. So this fixation is called segmental fixation. You just fix a segment that has been diseased, correct that part and fix that part. And segmental fixation doesn't work. And we have published some case series showing that, and we came with this concept of long segment rigid fixation, which seems to be the game changer. This patient clearly has a rocker bottom midfoot deformity. What we do is take bone resections to correct the shape, and then we calculate beforehand the amount of bone and where and how much you need to take. Then you need to get absolutely perfect bone opposition, 100% bone opposition, and 100% rigid fixation using, on this occasion, these plates and screws, but on a different occasion, it tends to be beams and bolts and so on. So it's the same concept. In this midfoot case, an actively infected midfoot plantar ulcer, again, this has to be done as a two-stage procedure. This because infection is active there. In the first stage, excise the ulcer, excise all the osteomyelitic bits. You have to be very aggressive and thorough with your debridement, and then temporarily stabilize the foot with these wires so that the foot won't be too floppy. And then continue with your targeted antibacterial microbiological treatment. And then once the clinical and radiological, there is radiographic evidence of infection eradication, then you can go back and reconstruct, because unless if you reconstruct and achieve full bone fusion, the deformity will come back again. So that was the midfoot, and we applied the same principles to the hindfoot as well. Hindfoot is a killer disease, hindfoot Charcot, and that contributes to most major amputations. And this patient who had previous failed circular frame treatment and obviously is still struggling with his mobility, then we offered an internal fixation treatment for him. Again, bone biopsies helped us identify what the organism was, so we just went ahead with as a one stage. So it's almost like building blocks. You make the foundations right, do the foundations part first, which is the ankle part here, and then build up. Based on the shape and position of the ankle, you bring the hindfoot, and then you bring the midfoot to the correct position. So on this occasion, using a rod, intermedial nail and plate, we were able to achieve a plantigrade, completely solid foot so that the patient can wait. This procedure was done quite a while ago, and this patient is still very mobile. Another example of severe deformity, again using the same principles. I won't go through in too much detail, using the surgical technique of again starting with the ankle and the subtalar joint, the midfoot joint, correct the ankle first, and then bring the subtalar joint around or calcaneus in line with the rest of the bones, and then bring the midfoot in line with the rest of the reconstructed bones. So you achieve this type of fixation in that extreme. But the key thing is to achieve a plantigrade stable foot. If you achieve full bone fusion, that correction is permanent. And but if there is aggressive active infection, such as this, and similar to the midfoot infection we saw earlier, these require a second stage. Well, can this be salvaged? Well, this patient was actually an inpatient at a neighboring big hospital. Patient was very busy. He actually he was in the production company for a major Hollywood very blockbuster series, and you know, he didn't want to lose his limb, so he got himself transferred to our unit. And the problem here is that the debridement done, initial debridement done, was inadequate, because if you use the RAG model, red, amber, green, all of that would be amber. So it means all of that needs to be removed. So you have to achieve infection eradication. That is the first step. For that, debridement has to be very aggressive. This was done about 7 years ago. I didn't have any plastic surgeon. Even now, the role of plastic surgeons in our unit is still not massive. So, but with VAC dressing, VAC is your friend, beautiful granulation, and then skin grafting, you have got full skin cover. But the deformity, that acute Charcot, continued to deform as it would be, because the bones were not stabilized. Not a problem. Once you achieve infection eradication, you can go back and reconstruct. On this occasion, this patient, we had to use quite a lot of metal work. It has been over 4 years, and the patient has been mobilizing. Another similar serious example, you know, the diabetes with neuropathy is such a challenging medical comorbidity for orthopedic surgeons, because, you know, even when you, with your best intent. So this nail was the 4th procedure done for this patient who presented with an ankle fracture to that big hospital. So even that nail got infected. So then what we did was that I removed all the metalwork and then impregnated with antibiotic loaded calcium sulfate, because we had the deep tissue sample related microbiology results. We knew what exactly antibiotic we were going to use, and then let the infection settle and then achieve infection eradication. So the wound is closed now, the wires are still there, the CRP has come down and stayed down, and then you make a plan. So yes, you're going to reconstruct the hindfoot with the nail and additional screw, and midfoot like that, and that is the kind of fixation we achieved. Foot shape is back to normal, and there was no recurrence of infection. So the presence of infection doesn't necessarily mean that those limbs need to be amputated. So I have done 117 Charcot foot reconstructions, equal split of midfoot, hindfoot, and combined, and we have published our experience. But overall, the outcomes are very, very encouraging. We haven't lost even a single limb among those reconstructed patients. 88% of bone fusion, and much higher percent of ambulatory status. So I would like to finish my presentation by reminding everyone joining the meeting that, you know, this requires a very aggressive multidisciplinary treatment. Vascular management is very critical. Infection control is absolutely mandatory. Advanced wound care, it can be as simple as VAC dressing and routine dressings to plastic surgical procedure. But durable fixation, this is the mantra we use for this fixation. Anyone comes to our unit for training, they have to repeat this mantra. Long segment, durable, rigid fixation with optimal bone opposition, plus or minus bone stimulation, plus or minus local antibiotic elution. If you use that principle, you can achieve amazing results. But multidisciplinary approach is critical. All of this credit of all this, good outcomes among these 117 patients go to the whole team. So with that, I would like to thank you all for your attention and for this opportunity. Dr. Rajesh Keshavan And the DFSA, an amazing organization, and it has a massive potential in improving the care of diabetic people in India. Thank you.
That was an excellent presentation, Professor Venu. Again, you had dealt on, I mean, you mainly said, again, any acute swollen, red, inflamed foot, you have to rule out Charcot. You have to.
You're right.
And
there you are, yeah.
And the other thing is, there is no effective medical management of this disease even now. That is one thing. And
Yes.
the rest is the most important form of treatment, that too by a total contact cast, that again has the most best treatment and best outcomes.
Yes.
And for hindfoot Charcot, and wherever there is a instability, not just hindfoot, even midfoot with instability and ulceration, you need to think about surgery, you need to plan, and it is going to take a long time for the patient to recover. And
Yes.
the patient may be avoided in many of these patients. So this was, again, the main takeaway of your lecture. That is what I assume.
Very well summarized.
Yes.
Yes.
And a number of questions have come up.
Yes.
Can I just start them?
Of course, please. Yes.
Again, you said, again, the casting time is 6 to 18 months as per the various studies that have come up. Again, here in India, my experience, again, I see about 2 or 3 Charcots every week. In our experiences, about 3 months, most of the time, the patients are able to shift to footwear and maybe a partial weight bearing. Very, very few patients we have gone beyond 3 months. Is there a reason why you are going for 6 months? So I think, again, many of the patients get disillusioned when you say you need to be off your foot for about 6 months. What are your thoughts?
If you look at the published data, Rajesh, that's reasonably old. In those days, at least certainly for our practice, that the patients used to come a bit late.
Okay.
So we were almost unheard of stage 0 presentations in the past. So, and most of these presentations, so that total duration also includes full weight bearing.
Okay.
So only part of that is non-weight bearing. And then until the surgical shoes or whatever definitive brace or device is going to be made, the patient continues walking in full weight bearing in the cast. So full weight bearing in a total contact cast with an outer sole is like walking in your own custom made shoe. But so it includes all of that. So if I share the current practice in our unit,
okay,
a number of patients come to us in stage 0, and most of them don't need to have the cast done for more than 3 months. A lot of them come in stage 1. A lot of them don't need to have the cast for longer than 3 months. But some patients still come late, particularly with instability, and those patients may need longer. But we are a bit more proactive with surgical management. Now, even I suspect that even those patients who have the cast on for more than a year, and the reason for that is that there is no bone consolidation in some parts of the foot, and it's quite likely that they will have instability. And in those days, there was no provision. If you look at the Charcot foot reconstructions using the current principles, we've been doing, only a few centers have been doing for the past very few years. Acute Charcot reconstructions were considered as very, really, really high risk until very recently. So a lot of these patients did not have any other alternative but to continue in a contact cast. But in the current scenario, a lot of these patients, yes, in an acute Charcot, if the foot is becoming at risk, rather than frequently changing the cast, they will probably be subjected to acute Charcot reconstruction. In that way, the foot shape will return to normal. They will have less risk of recurrence of Charcot, and they will have less risk of all sorts of complications that can lead to limb loss. So I think that, yes, that published literature is a bit old, and I don't think that represents the current practice. The current practice, since the introduction of Charcot foot reconstructions, has actually revolutionized the way we manage acute Charcot.
Okay. One question from Dr. Gauri Tamhankar from Karad in Maharashtra.
Sure.
How do you differentiate an acute Charcot from an acute osteomyelitis?
Sure. So it's a combination of clinical and investigations. Clinically, I mean, there is an acute Charcot is an abnormal neuropathy-driven inflammatory response. So that neuropathy includes autonomic neuropathy and everything. So yes, you see evidence of diabetic neuropathy. You also see vasodilation. The veins become very dilated, and the swelling responds to leg elevation and so on. So clinically, you don't see any bone changes. Clinically means if you try and do gentle manipulation of the bones, you don't feel any crepitus, you don't see any abnormal motion. Sorry, that is for the infection. So in the Charcot, I will recap again. So this swelling is associated with autonomic neuropathy related changes as well. The veins are dilated, hyperdynamic circulation type. Then the swelling often improves with the leg elevation, but it's not a very common practice nowadays. And the third thing is, when you palpate, you don't feel any bone signs such as bone crepitus and abnormal bone movements. So a blood test, particularly CRP, shows slightly raised levels, but very, very, very rarely, almost never above 50, usually below 20. So there is no skin breach. Skin is completely intact clinically as well. When you do MRI radiograph, MRI are plain, well, let's talk about plain radiographs. If it is stage 0, it's normal. Stage 1, you see typical subchondral bone changes. An MRI shows typical bone marrow edema along with soft tissue changes. So that is the acute Charcot. If you look at an osteomyelitis, number one, there will usually be some source of infection. If it's an osteomyelitis is from an ulcer, you will see an ulcer of the skin breach with cellulitis leading to osteomyelitis. That's different. And the second thing is plain radiographs show long-standing changes. So osteomyelitis with sclerosis and so on. And MRI shows different changes. CRP is very valuable for us. CRP is always greater than 50 from our experience. Of course, there is some patients who don't throw CRP as much. So this is a combination of clinical, serological, and radiographic assessments. Sorry, I can't hear you.
No, CRP more than 15 or 50? What was the number?
50.
Okay, please continue.
So that is the kind of so in fact most often when you think that it is osteomyelitis, it is not. It is an acute Charcot. So how can you have a definitive diagnosis? Is by doing an ultrasound guided aspiration or bone biopsies, and that should be done very quickly. You should not spend too much time, delay the diagnosis for too long, suspecting osteomyelitis because you want to offload that acute Charcot as soon as possible. So you are muted. You're on mute again. Sorry.
Okay.
Yes.
And one question on the cars. it's a non-weight bearing cast, correct? Some people tend to use a weight bearing total contact cast.
Yes.
Um, Again, you
Now,
have this Scotch cast boot, which does not go up to the upper leg. It's mostly up
sure.
to the ankle. How do you find using a Scotch cast boot? What is your experience with weight bearing versus non-weight bearing total contact cast?
Sure. Right. If I come across a stage 0 patient, I would generally go for full weight bearing in the total contact cast, unless if the patient is extremely non-compliant. So, if stage 1 with very minimal bone fragmentation, bone shape is still intact, you can go for full weight bearing in a patient who you can trust. So, but if it is if there's significant fragmentation, then it is if you go for weight bearing, number one, the healing time will be delayed, will be prolonged. Number two, the foot will deform. So the TCC can limit the degree of deformity, but it can't stop. So in that situation, so that is weight bearing versus non-weight bearing. Now a Scotch cast boot, which is below the, to the ankle level, doesn't provide enough mechanical support to let them weight bear at all. So in an acute Charcot, no, it doesn't provide enough. So you say a standard total contact cast not only distributes the plantar pressures, it also actually transmits some of those plantar pressures to higher up the leg. That is the beauty of a TCC. But these Scotch cast boots don't provide that kind of support. So on the other hand, there are modern casting materials coming up. I don't want to discuss in detail about these. Those that come with mesh shape and so on. So they can provide better aeration, and if they provide equally good mechanical support, they may be considered. But we don't know well enough about these, whether they provide same level of cutaneous and skeletal support as a total contact cast.
I think one question by Dr. Parekh from Navsari in Gujarat. Who are most like? Why do some diabetics develop Charcot and others do not? And is there a way to find out who are more likely to develop Charcot? That's a very interesting question.
Well, if anyone can find this, that person will get a Nobel Prize. Well, the close to that is the presence of neuropathy. If there is full spectrum of diabetic peripheral neuropathies, the sensory side, the small fiber, large fiber, and autonomous, then the risk is significant. But in some patients, you don't see large fiber neuropathy. They tend to have normal sensation, but they have already got small fiber neuropathy. Patients don't often appreciate, and we as clinicians can't identify that easily unless if we do advanced investigations. So the small fiber neuropathy is the key. If the small fiber neuropathy is there, then the risk of developing Charcot is there. But if there is full spectrum of neuropathy, the risk is even greater. But there is no clinical, serological, or investigative biomechanical marker that can quantify the degree of Charcot risk.
One question from Dr. Bijoy Bhattacharya from Kolkata.
Right.
What percentage of patients would require a flap cover?
Sure.
I think yeah.
It is so variable. It is so variable between different practices. So I will share my experience. So we started doing these reconstructions about 15 years ago. And about 10 years ago, we felt that a plastic surgical colleague would be good to have. So we applied to the trust for a plastic surgical fellow, and it took almost 5 years for them to approve. So we appointed a plastic surgeon maybe about 4 years ago. And by that time, we learned how to not to need plastic surgical support. And in fact, our plastic surgical colleague, a good friend of ours, but he has very little to do. But having said that, it all depends. It depends on. It's not. I'm not saying that there's. That's our practice, and I'm not saying that there's no significant role. And there's a significant role from him. He's part of our MDT, and he knows when he can help. So a large free flaps is almost impossible in these Charcot reconstruction patients because most Charcot patients, chronic deformed Charcot patients, have got some degree of distal vascular problems. And in fact, some recent studies have shown a very high incidence of significant vascular compromise in the patients, among the patients that are present with chronic Charcot. Even though in the past we know that an acute Charcot is not associated with vascular problems. In effect, if someone has a vascular problem, that person may be protected against an acute Charcot because there is not enough circulation in the foot to create this kind of inflammatory response, vascular-driven inflammatory response. But now we know that a number of these chronic Charcot patients present with vascular problems, so they can't have free flaps, most of them. The thing they can do is local rotational flaps in a number of patients. Skin grafts, we generally do by ourselves. Even the local rotational flaps, the biggest they can do is the medial plantar flap. But the rest of the times is the local rotational flap for the ulcers. So, and in our practice, they've done medial plantar flap on 2 patients out of these large numbers. Not only Charcot, even another group of patients. And whereas a local rotational flap for ulcer coverage were done by us on a few occasions. So our practice is quite different. We rely on vac dressing a lot. We got 8 highly skilled podiatrists, and they are super experts in all these things. You saw some case examples I've shown. So even those patients didn't require vascular input.
One interesting question. Dr. Ravindra from Pune, he has asked this question. In presence of an ulcer in an unstable Charcot ankle, is it safe to do internal fixation?
Sure. So ulcer is 1, infected ulcer, active infection, 3 types. The presence of an ulcer is, we have published our Hindfoot series about, I think, 7-8 years ago, or 6-7 years ago. In fact, presence of an ulcer is not a contraindication. And that was a kind of major shift in our mindset. As an example, as an orthopedic surgeon, if I have a patient for a hip replacement, if the patient has a tiny toe ulcer, which is far away from the hip, we don't do a hip replacement in fear of that ulcer getting infected and that infection spreading to the hip joint. That was the kind of mindset we had before. But in these patients, we are in a catch-22 situation. The ulcer won't heal unless if you correct the instability or deformity, and you don't want to operate unless ulcer heals. So what we have seen is that the presence of an ulcer is not a contraindication for 1-stage Charcot foot reconstruction, even with using internal fixation. You need to do aggressive ulcer debridement, wash out, and then redrape the patient and do the rest of the procedure. It's extremely powerful. So as you are going to correct the deformity and during this process, you also shorten the limb, because to do the bone wedges, you take a bit of bone. So that will shorten the limb by about between 1 to 2 centimeters. That also decompresses soft tissues, that improves soft tissue healing. And the ulcer heals very quickly with vac dressings. But if there is active infection of actual infected ulcer, you have 2 options. Either you do the ulcer debridement and do an external fixation. That means that you don't pass the metal through the infected part. That's a very good option. Then other option is do as a 2-stage. Debride the ulcer, get rid of infection, using the case as similar to the case examples I have given. And once you eradicate the infection, you can do the internal fixation. The advantage of internal fixation over the external fixation is that now we know that the fusion rate is greater with internal fixation because you can bring the pieces together to the position where you want using the techniques, and you can compress. And this fixation, you don't have the risk of the external fixator having to be removed because the patient can't tolerate or pin site infection, other things. So even the two-stage reconstructions from our case series do not carry high risk of infection. So my fellow is currently going through the two-stage reconstruction case series, and that will most likely be published sometime soon. But I know that infection recurrence rate is still small, but if you follow that kind of protocol.
This question from Dr. Sangeeta from Hubli, Karnataka. In a government setup where facilities for cast is limited, can we use a plaster of Paris cast, which is already available, to put a TCC? If so, how many layers of POP should be used?
Sure, absolutely, why not? In fact, the plaster of Paris will give you the same level of support, absolutely. Now, how many layers? Obviously, you go round and round. So I haven't shown you the video of the TCC. Perhaps that would have helped, but that would take about 10 minutes or so. Basically, when we do using the Scotch cast, we go around 4 times. And for most plaster of Paris, it will be similar. Maybe you can maximum around 5 times. So how many do we use? If you use a 4-inch, we normally use 4-inch and 3-inch. If you use a 4-inch and 3-inch, we use 2 each. Yeah, in a big patient, use 3 and 2.
And she has, again, Dr. Sangeeta has one more question. Do you prefer a lateral approach or approach to the plantar aspect while doing an osteotomy in Charcot foot in view of avoiding pressure? I think she's looking at a midfoot ulcer.
Understand.
Osteotomy.
I have deliberately removed all those slides on this technical part, and quite clearly I thought, the audience are predominantly medical. Yes, basically, I can tell you about the technical aspect. Before you plan your surgery, you need to assess the soft tissue and bone components of the deformity. And midfoot deformities come with specific patterns. If the medial column only gets affected, the medial column collapses. That results in rocker bottom, and that pushes the forefoot into abduction. So it's called rocker bottom forefoot abduction type. We call it pattern 1. And for that, you can do everything from the medial side. Medial approach, you can take medial and plantar-based wedge resection and correct the shape and fix. So no plantar approach, medial approach, but it can be dorsomedial or plantar medial, depending on where the bone prominence is. If there is a lot of bone prominence in exostosis plantarverse, you can make your incision slightly plantar so that you can access that part as well, and dorsomedial. But if a different pattern, if it is a forefoot adduction type, which is very rare, but not very rare, less common, it's due to failure of the lateral column usually from stress fracture or Charcot, then forefoot goes into adduction. Then you have to do a lateral approach. So the approach should be towards the convexity of the deformity, so that you can go directly to the deformity, take the wedge dissections, and fix. So plantar approach is usually done if we're doing exostectomy, but you can still do plantar plate for the medial column using the medial, dorsomedial, plantar medial incisions. So that is the kind. But I suggest you, if you're interested in that, I suggest you have a look at an article that was published on Charcot midfoot reconstructions. I have written that was published in Annals of Surgery beginning of this year on Charcot midfoot reconstructions using patterns-based approach, and that describes all those patterns. And there's also, I've done few webinar talks And I think the ADFS talk was on midfoot Charcot reconstructions, and that is actually on on YouTube as well. You can simply Google and find that presentation with explanation on everything.
I think we are coming to the last question. I think we are coming to the end of the session. Time is getting over.
Yes.
This is from Dr. Ashwardhan Shirshat from Nagpur, Maharashtra.
Sure.
His question is, where do amputations stand in the scale of treatment?
Sure. I mean, amputations were very frequently done in the past, and there is still a major important role for those. But it is, as we came to know about 16 years ago, that amputations carry a very high risk of mortality. And we weren't really aware of that until 2 decades ago. Then we started looking for limb salvage, functional limb salvage options. So yes, if there is severe bone loss and severe infection and very limited soft tissue cover, you can't reconstruct those. But fortunately, that situation is less common or rare. 4-foot amputations, we're talking about, so the major amputations we should try and avoid as much as possible. So functional limb salvage. You salvage the limb, but that limb should be functional, is the aim. If there is limited vascularity, you don't have options. If a critical limb ischemia, you have to amputate. But amputation just because of the deformity is no longer a good practice. So there are very well proven ways of correcting the deformity, preventing ulcerations, getting rid of infection, and give functional limb salvage. 4-foot amputations are actually, if necessary, if required, are very powerful. They can potentially prevent a major amputation. Transmetatarsal amputation is also very powerful. The patient can retain very good mobility in a good pair of shoes and insoles, even after 4-foot transmet amputation. Charcot amputation, also that is the limit, but when you go up further, the mobility reduces significantly. And a bony amputation, in a very reasonably fit patient, why not? If the prosthesis can fit, but you know that only 20% of patients can have a prosthesis after a year, and it's a lot less after 2 years. So, but it has to be individualized. But those days are gone. Those when we felt that it's a bit difficult to salvage this, let's amputate.
I think Professor Venu, that was a very good presentation. You covered all aspects of Charcot foot, from diagnosis to management, medical management, as well as surgical management, how to go about complicated surgeries. And again, it was very enlightening to all of us. Thank you for joining us. And I would like to thank all the DFSA members for taking part in this lecture from the length and breadth of this country. I'd like to also thank Sun Pharma for making this possible. Thanks a lot. I think we'll conclude this session now. Next week, we will have another session of our DFSA webinar series. Thanks a lot, everyone.
Thank you very much, Dr. Rajesh. Thank you, DFSA. Thank you, team.
Thanks a lot, sir.